Welcome everybody to today's webinar, the VALA COVID discussion, Virginia's COVID response related to assisted living facilities. My name is Judy Hackler. I am the Executive Director for the Virginia Assisted Living Association, also known as VALA. We will get started with today's meeting, but first we will have a couple of housekeeping information to go over. As with any of our presentations, we like to remind everybody about the antitrust reminders that we want to make sure that all of the discussion and conversations held on the webinars are not going to be in violation of any of the laws, whether it be federal or state or local. Please mute your line when you are not speaking. *6 can unmute telephone lines. You can also raise your hand to be unmuted by the host, and you also invite you to use the chat feature to share any questions or comments. Discussion is being recorded to be shared on the VALA's Health Alert webpage. The presentation slides will also be shared online with clickable links. You may have received a draft version of the presentation slides this morning. If you have not received it, then please do check your spam folder if you would like to follow along on those slides. But please know that some of the slides may have changed since the original publication. This discussion is not intended for the media. If you are a member of the media, please disconnect and contact VALA if you have any industry-specific questions. Statements and information shared are a work in progress and may change. This program has been approved for continuing education for 1.5 participant hours by NAB. Only those participants pre-registered for the webinar and participating in the live webinar presentation are eligible for the CEUs. Please remember to complete the program evaluation. CEUs will be uploaded directly to NAB for participants that have shared their NAB registry number with VALA. All participants will receive a certificate of participation, those that were pre-registered. Some additional resources available to you is the VALA Health Alert webpage. There's also links to the VALA Virginia Long-Term Care Task Force webpage, the Virginia Department of Social Services, and the Center for Disease Control and Prevention. Special guests that we have with us today, and there may be additional ones from each of the agencies, which we welcome. From the Department of Medical Assistance Services, Thomas Gates, Bill Lessard. From the Board of Long-Term Care Administrators, Corey Tillman Wolf. Virginia Department of Social Services, Kathy Peterson. Virginia Department of Health, Deborah Burkhead Hopkins. Christy Gray, Michael Magner. Virginia Department of Labor and Industry, Jennifer Rose. Preliminary discussion agenda. We're going to go over some of the funding opportunities for assisted living communities. We're going to go over the assisted living administrator licensure and training updates, reopening updates, PPE, testing, infection prevention and control, as well as information on the Department of Labor and Industry's workplace safety standards and General Assembly updates. If there is time at the end of the presentation, then we will also have other discussion related to COVID or other industry-specific items. Now I'd like to welcome to the presentation Thomas Gates from the Virginia Department of Medical Assistance Services to provide us updates on funding opportunities. Welcome. Thank you for joining us.
Absolutely. I just want to confirm folks can hear me?
Yes, we can hear you fine.
Great, thanks. So just a quick update today. We have, the last time I talked to you was probably back in August. And since then, I think we've put out more guidance in terms of how to enroll, what eligible costs are. I think VALA helpfully provided links to what we've put out so far in the content that was sent out for this meeting. That includes our letter kind of describing how to enroll, what eligible costs are for reimbursement, and then also links to the form you need to use to enroll and the document you should use to capture costs and invoice us. So we have had folks enroll. I would say we've had a little under 200 assisted living facilities enroll, which is less than half of what we think the total eligible population is. Really, again, just to stress, this is, which I think this community knows, you do not need to be a Medicaid provider to participate in this. There's not a, we are running this program, but we are doing it with CARES Act dollars. It's not technically Medicaid funding. So even though DMAS is the agency that is running the project, it's not Medicaid. You do not need to be a Medicaid provider to participate. So if you are not participating and you'd like to, I encourage you to take a look at those documents that VALA shared. Reach out to us if you have questions. We also have on board a contractor, Myers and Stauffer, MSLC. They work with us very closely with the nursing facilities and with hospitals, help with our cost settlements and things like that. And they are providing kind of administrative support and doing the initial review of invoices. So if you have questions, there's a email listed in the welcome letter that you can send questions to. Just for a quick update on kind of how much volume we're seeing. So I said we have a little under 200 enroll. We have so far 179 invoices for the month of July, 101 for the month of August, and we've started getting the first couple for September. I think there has been a learning curve in terms of the kind of documentation we're looking for to validate that these are COVID-19 related costs. My understanding from talking to MSLC is there has been a fair amount of back and forth. I think we've only got 50 or so invoices last time I checked that have actually gone through for payment out of that first 179. So that partly I think is back and forth on kind of the documentation we need. If you guys are seeing any sort of structural problems or anything like that, I'd be interested in hearing about it for sure, so we can help address that. The other thing I did want to kind of just call attention to that we don't have answers on yet is, I'm sure you guys have noticed, or maybe we will discuss in the General Assembly update, that there was language in the budget conference report that was approved. I can get the number. It is item 3135C, and that language directs us to change the eligibility timeline. So you guys are aware the original timeline for eligible expenses was July through October, and the General Assembly is directing us to move that date back to March 12th or as early as the CARES Act would allow. I think our initial read is we think that would go back to March 1st. That's what the CARES Act guidance says. This has not been signed by the governor yet. It's not law yet. It's not a real thing yet. But we are obviously taking it seriously since the General Assembly passed it and starting to look at how we would implement that if that does get adopted. And so you will likely, if that if the governor signs that and it becomes law, you will likely see an additional letter from us that will provide an update on how we're handling this and a new invoicing sheet, because we will need obviously documentation and invoices for COVID-19 eligible costs back to March, instead of just back to July. So that is kind of a TBD. It's breaking news, as it were. But once that's settled, once the budget is enacted, if that provision is still in there, you can expect to see, and we will certainly share with VALA to share out to the membership additional guidance from us on how to look back further. We're still kind of looking at how we would implement that dollars-wise. It obviously expands the total amount that any individual ALF could receive, because as you guys are probably aware from the last time I was speaking, you can get up to $4,000 of eligible expenses covered per month. So that's 8 months instead of 4. So there's a higher threshold there. The General Assembly did not direct us to provide any additional dollars to this, and our initial guidance does say that this program is contingent on funding availability. So if we get to a point where we do not have enough dollars to cover all the eligible expenses that have been submitted, we will start paying on a prorated basis. That said, if we do not spend all the money and there are still kind of remaining unreimbursed expenses, we will go back and reallocate that remaining funding to facilities that had eligible expenses that we weren't able to reimburse because of the caps. So that's all kind of TBD based on what we see in the invoices. What we're seeing right now, I am not particularly concerned about running out of funding with what we have available. If there is a big uptake, that could change, and we will kind of stay in contact with the community and with the governor's office if that becomes an issue. But like I said, that's all kind of up in the air right now, just because we're in between the General Assembly passing and the governor signing. But that's probably the best update I can provide on that until we know more. But with that, if anybody has any questions, I'd be happy to provide whatever answers I can. And you can put them in the chat, or I imagine maybe get unmuted.
Well, that is a fantastic update. We truly appreciate the breaking news of being able to have the retroactivity for the funding opportunities. That is definitely something we've been advocating for, so we appreciate that update and look forward to getting additional information on how that's going to be implemented. And of course, we will share it out with our members and also on our social media and email broadcasts once the information is finalized and able to be shared. Are there any questions specific to the Virginia portion of the COVID relief funds? And again, you can raise your hand in your participant box. You can also chat, send a message that way. I also did want to provide an update. We do have links on the slides for the HHS Provider Relief Fund. They are now in phase 3 of the distribution, and assisted living communities are eligible to receive funding under that distribution. So there are links on the slides that will be sent out following the presentation with the final version of the slides, as well as it will be posted to our website. Links include information on the general information on how to apply for those funds, as well as frequently asked questions on the CARES Act Provider Relief Fund. Thank you, Thomas, for those updates. We will move on in the presentation. Next up, we have Tillman Wolf with the Virginia Board of Long-Term Care Administrators with some exciting updates on administrator licensure and training.
Great, thank you, Judy. Can everybody hear me?
Yes, we can. Thank you.
Okay, perfect. Great. Good afternoon, everyone. I just want to take the opportunity to briefly touch on some updates from the board related to administrators and some of the licensure and training updates specifically related to COVID. I'll touch a little bit about some of the recent updates for CE requirements for administrators, particularly for the 2021 renewal. I'll also talk a little bit about some of the recent updates related to administrator in training, and then also give an update on where the board is in the process related to some proposed changes for the licensure process, specifically for individuals interested in pursuing licensure as assisted living facility administrators. So we'll touch on those in turn. And Judy, if you wouldn't mind forwarding to the next slide. Thank you. And so just first and foremost, for the continuing education requirements, this is just the existing regulation for administrators. Normally administrators are required to complete those 20 hours of CE for renewal each year, and then up to 10 hours can be online or self-study. The initial 10 are typically live or in-person hours. And so just moving to the next slide, just to give you a little background, as most of you know, for the March 2020 renewals, you know, the COVID pandemic really ramped up in mid-March, just before that March 31st renewal deadline this year. So at that point in time, the board had made 2 accommodations for renewing administrators, a blanket 6-month extension for completion of CEs for the administrators who had not yet done so. And so there was a handful of administrators who availed themselves of that. And then also made an allowance for live in-person coursework that could be completed by a live teleconference or webcast during that 6-month extension period. And next slide, please. And so looking ahead to the upcoming year of renewals and some of those continuing concerns that existed for CE and completing the CE requirements at the September 2020 board meeting, the board did again make some additional allowances for next year's renewal. And so first, the board granted a partial exemption from the CE requirements for next year. And so that is a partial exemption from completing 10 of those CE hours. So that means that for renewal of licenses next year, all the administrator licensees will only have to attest to completion of 10 CE hours for the previous year, instead of the usual 20 contact hours in order to renew a license. Those remaining 10 hours can be obtained really through any way. Live courses, and those are both the in-person courses and the live teleconferences and webcasts that we'll talk about here in a second. Also online courses or self-study courses. And so for anybody who's already completed more than those 10 hours for the next renewal cycle, the regulation also allows for those excess hours, up to 10 of those excess hours can actually be transferred or credited to the next renewal cycle. So that would be the 2022 renewal cycle. So as administrators are learning and really including this CE course today and a lot of the other information that's out there with COVID, you may very well be able to use that for the next couple of years in effect. So this partial exemption really only applies to the 2021 renewals. It doesn't impact any of the educational requirements for the other regulatory agencies, so DSS or OLC, and any requirements they may have or that they may have also waived. In addition, those live in-person courses, the board did extend that same guidance to allow administrators to have those hours completed through attendance of real-time interactive programs via teleconference or webcast. So that is ongoing, at least through the public health emergency duration. And the board did create a guidance document to reflect that extension or that interpretation. And you'll see the public comment period is open on that until November 11th, and that guidance document is otherwise set to become effective November 12th. So, and this guidance document also provides some interpretation or guidance regarding the signature requirement for CE certificates issued by NAB-approved courses. And I know Ms. Hackler brought up that question to the board, and so that information is included in that guidance document as well. So just very briefly, also due to COVID, the board has received some calls from administrators in training, particularly AITs, who are either unable to be in a facility for training or who are unable to find preceptors who are willing to train. We also received a question related to preceptors who are not able to actually physically be in a facility where they're not actually an employed member of that facility. So the question came to the board: what if a preceptor is not permitted to enter a facility where their AIT is actively training in order to be routinely present with their trainee? And that could be not permitted to enter for a number of reasons. But the board did issue some interpretive guidance in that area to allow for, and you'll see on the next slide there, to allow for preceptors to fulfill that routine presence requirement by communicating by video technology with an AIT who's physically at the training facility, obviously with appropriate measures to ensure that resident information and records are and remain confidential. So the board took the approach of allowing that video face-to-face communication, if you will, during the COVID pandemic. So the board also did, with some of these AIT and preceptor issues, indicated that it would continue to look at the AIT issues on a case-by-case basis but the board did not really take any action regarding the AIT training requirements beyond this general routine presence guidance that we just discussed. And so next, just to give you an update on where the board is with some of the pending recommendations on changes to licensure qualifications. As with a number of regulations, these regulations have also been significantly delayed due to COVID this year. The board worked last year with a regulatory advisory panel of administrators, of provider associations, of state agencies, and the panel itself made recommendations for some changes to the regulations to improve the training for prospective administrators. It also included a recommendation related to an additional experience pathway for prospective assisted living AITs to have the ability to become AITs and then eventually become licensed. The board issued a notice of intended regulatory action in December of 2019 to start that process of amending the regulations. But as it stands at this point, and next slide, please. That Nora is still currently under review in the Secretary's office. One of the qualifications of note that I know is of interest to the AL administrators is also looking at an additional qualification for licensure for an assisted living AIT program for an individual who has had defined previous experience in a managerial or supervisory role in a healthcare setting, and then also looking at some additional coursework in lieu of a 30-hour accredited institution coursework requirement. So this would be another pathway essentially for accessing the assisted living AIT program and then also assisted living licensure down the road. So that is in the regulatory proposal, but again, it's currently under review in the Secretary's office. You can access that information on the Virginia Town Hall, and that link is provided in your PowerPoint. And we're on, just so you know, day 272 of review. So it has been out there for a while. If you have any questions, here's the contact information, and I'm happy to answer those questions. Thanks so much.
Thank you very much for that update. We're looking forward to the recommendations getting approved eventually. So we do encourage that from the legislators and from the regulatory offices. So thank you for that.
Yes.
Any questions or comments? If not, we will move on to reopening updates from the Virginia Department of Social Services.
Hey there, can you hear me?
Yes, we can hear you.
Thank you all for joining us today. Just wanted to go over our ongoing work with VDH. We are working feverishly to update the recommendations that we have for our assisted living facilities during the COVID pandemic. These recommendations will be updated, and we hope to have them out here within short order, hopefully within the next couple of weeks, that will provide updated links and recommendation guidance that will help our providers during this pandemic. I'm going to hand it over to Lee Burke. She's going to go over a little bit more specific information on what these revised recommendations will include. Lee?
Thank you, Kathy. Hello, everybody. I just wanted to take a few minutes to follow up with Kathy. You know, we did have a phone call this morning with VDH where we discussed their revised guidance that's going to be coming out, and to discuss what they thought we should be putting out in terms of our guidance as well. We're going to make every effort to mimic the VDH guidance for nursing homes as much as applicable and appropriate so that we're sending a consistent message, particularly for those facilities that are CCRCs and you know, have assisted living and nursing homes under one roof. So the look of the document is going to be different than we had initially planned. And we're going to have lots of additional links and additional resources for you all to go to based on the topic that is the category that's being discussed. So within these revised recommendations, we're going to be talking about general prevention measures, hand hygiene, PPE. And in terms of PPE, it'll not only be general usage, but PPE specific to COVID, cohorting, environmental cleaning and disinfection, new admissions, readmissions, visitation. And of course, regarding visitation, there is a task force, a subgroup as part of the long-term care task force that's working specifically on visitation. So additional guidance will be coming out as well whenever they're finished putting that together. Testing recommendations, vaccination planning, and this also includes flu vaccine planning and data, special populations, and this is going to address residents that have to leave for dialysis, facilities that serve primarily mental health populations, communication, and this would address family members, primarily residents, reporting, ensuring that you're reporting to not only us, but all the other appropriate agencies, particularly if you have a CLIO certificate, a CLIO waiver, training, and this would address N95 training and a couple of other topics, and tools that you can use for infection control prevention, like the infection prevention and control assessments, the IPC through Virginia Department of Health, and the outbreak line list that's currently on the Virginia Department of Health website. So that's our plan for right now. And like Kathy said, hopefully we'll have this out within the next couple weeks for everybody.
Thank you, Lee. Just wanted to touch briefly on PPE and distribution. We are continuing to have ongoing distribution of PPE for facilities that are reporting weekly their PPE burn rate and inventory. Those distributions have been changed, obviously, throughout the pandemic. We've been trying to perfect our systems a little bit. So the PPE on a weekly distribution is being delivered directly to the facilities. We are still strongly encouraging our providers to report your weekly usage and inventory, especially as we enter into flu season and the need that you will have an ongoing and increased need for PPE. So really do encourage you all to report that on a weekly basis. As far as supply availability, there still is a lack of small and medium N95 masks. I just spoke with VDM and VDH yesterday regarding this. There is an ongoing order that they are receiving supplies and dispersing those, as the orders come in and availability is there. As far as any other PPE supply availability, as far as VDM goes, we're not having any issues, just the ones with the small and medium sized N95 masks. If your facility has not received fit test training, the Train the Trainer course, I would really encourage you all to have that completed, to get folks in your facilities trained so that they can adequately fit test your staff. Again, as we enter into the unknown season, and there may be dreaded thought of having to use N95 masks. So please really look into having that train the trainer course, having some folks trained to get that done for your staff. It'll do a world of good for you. I think that's it. Judy, go to the next slide. Is there any questions?
I did just want to reference the All Hazards Consortium. That was a link that was shared out by the Virginia Long-Term Care Task Force. And that is a PPE exchange system that is supporting organizations with the procurement of PPE. So if you have not looked into it to see if it would be something good for your communities, we invite you to look at that and see if anything there might be able to help you. Also, again, on the slides, you will have a link to the CDC and their links for optimizing PPE supplies. And of course, there are additional links on there for more specific as regarding face masks, gowns, respirators, any of the equipment that might be needed on how to optimize the supply usage. Thank you very much, Kathy and Lee, for those updates. We appreciate it and look forward to the future updates as well, especially with visitation, going indoors with the colder weather months. I know that a lot of providers are providing PPE for visitation, so that'll also put an additional strain. And so we do encourage providers to submit their usage reports so that the state can get a better idea of what they need to have on hand in order to support the communities. Next, we're going to have some testing updates. And so we have invited Deborah Burkhead-Hopkins to join us from Department of Health and provide updates on that.
Hi, how are y'all today? Just a quick little overview of CLIA before we've talked about testing. CLIA, for those folks that don't know, stands for CLIA Laboratory Improvement Amendments. CLIA is a federal program that regulates non-research laboratory testing performed on humans. CMS contracts with state agencies to carry the functions of CLIA out, and VDH's Office of Licensure and Certification is the Virginia State Agency for CLIA. The purpose of CLIA is to ensure quality lab testing. You may have heard the sentence, in order to perform COVID testing, you must be a CLIA certified laboratory. CLIA certified means that the lab or facility doing the testing has a CLIA certificate. The type of CLIA certificate depends on the complexity of the tests being performed. The FDA is who determines the test complexity. There are 3 complexity levels: waived, moderate complexity, and high complexity. Waived tests are simple, easy to use, and have a low risk for errors. There are 4 CLIA certificate types: a certificate of waiver, a certificate of provider performed microscopy, a certificate of compliance, and a certificate of accreditation. Your reference lab, hospital labs have a certificate of accreditation. Facilities that hold a CLIA certificate of waiver can only perform tests that are classified as CLIA waived by the FDA. Approximately 1/3 of the Virginia assisted living facilities already have a CLIA certificate of waiver. Many certificates existed before the COVID because these facilities were performing fingerstick glucoses or PT-INR testing on their residents. To help the COVID tests be available for use quickly, the determination was made to enable the FDA to issue emergency use authorizations. The authorizations allow unapproved tests to be used during this emergency. The EUA, Emergency Use Authorization, includes a letter of authorization that contains the FDA-determined test complexity. You'll hear the term point of care testing. This is a phrase used to describe the location of the testing is performed at the bedside or near the patient care area. Tests that are approved for point of care use can be performed by facilities that hold a CLIA certificate of any type. When the FDA authorized COVID tests for use of point of care during the emergency declaration, such tests are deemed to be CLIA waived. We have discussion a lot lately on the Abbott Bionex Now test antigen card. That EUA includes phrases such as lab certified under CLIA, authorized for use for point of care, use under a CLIA certificate of waiver. Therefore, facilities receiving a Bionex card test must be associated with an active and in-date CLIA certificate of waiver. A facility can submit an initial CLIA application using a form called the CMS 116 form. You can just put in your Google search engine, it'll come up. There's also a CMS CLIA website that has a downloadable CMS 116 and a certification quick link that includes instructions for the completion of this certificate, this form. The original application is mailed to our office, processed, and that generates your CLIA number. We'll email the contact person the CLIA number, because one of the changes CMS made during the public health emergency is allowing facilities to start testing once they have received their CLIA number. We do have a general email mailbox for questions regarding CLIA certificates, and that email is CLIALab, spelled CLIALAB, at vdh.virginia.gov. Facilities may also contract with a CLIA certified entity to perform COVID tests at their location. And I believe that's part of the agenda today. You're going to have some of your contract entities listed. The contract entity provides the testing personnel, and the testing personnel would be covered under that contract entity's CLIA certificate. These commercial partners already have a CLIA certificate with a multi-site exception for testing in a temporary location, such as your facility. Facilities that hold a CLIA certificate waiver are not routinely inspected and generally only have visits from our CLIA surveyors if there's been a complaint allegation filed. In some past years and in the coming year, there will be a certificate of waiver survey program. With this program, inspectors will go on site to ensure that the facility is performing only CLIA waived testing and are following the manufacturer's instructions for use. If a facility modifies the manufacturer's instructions in any way, the test is no longer considered CLIA waived. Things the surveyor will look for will include documentation of testing personnel training and environmental conditions for the kit storage and testing temperatures. While on site, the inspector will also ask for evidence of reporting positive and negative COVID test results to the state or local health department. We will be looking for evidence to support the CARES Act. CLIA is not prescriptive, so we're not going to be looking for a particular method of reporting or how it's documented. That is up to the facility to decide as far as CLIA is concerned. We will be practicing enforcement discretion for the use of COVID tests for screening purposes. There was a request to talk about testing updates and maybe some testing recommendations. CLIA cannot make testing recommendations. There are an independent board on the FDA website that talks about some of the comparisons and results that they have gotten for the different tests that are available. The last time I looked, I think there was 8 or 9 waived tests for COVID. Unfortunately, most of the studies that were performed by the manufacturers were on symptomatic patients and not on asymptomatic, not for the use of screening. So it doesn't really help you in a screening environment. There is some confusion between a CLIA certificate of waiver and waivers. The CLIA program is unable to approve a Section 1135 waiver request with respect to waivers on the CLIA program requirements. All CLIA program requirements are still in effect. Is there any questions?
Thank you for that updated information on CLIA. I know a lot of assisted living communities are interested in the program that maybe have not started the process on getting the CLIA certificate. We did get a question from some providers, and so I wanted to just put the information out there. with regards to who can actually perform the test within the community. And so there, on the slides, you will see update from the Board of Nursing regarding scope of practice, and that RNs and LPNs can complete the nasal swab testing if trained and an order from a medical provider is received. The nasal swab is not within the scope of practice for an RMA or a CNA. So just a little bit of information for communities there. And then if you want additional information on the CLIA certification process, you can go to the VDH CLIA website, and you can also use the email that was provided. And when we update the slides, we will also include that email address on the slides that Deborah referenced of the CLIA lab at vdh.virginia.gov. Any questions or comments on the CLIA certification? Just one more slide of updates on testing. I want to make sure that you know that there are several pages on the Virginia Department of Health website with regards to COVID testing. And so there's several of them, and they might have information that is duplicative, but each one goes into additional details. So be sure to look at that and share that with your staff members that might be needing that information for their jobs. So thank you, Deborah. We appreciate it.
Thank you.
Next, I want to invite Mike Magner to join us from VDH and provide an update on the vaccinations.
Hey, good morning, everyone. Am I coming in loud and clear?
You are, thank you.
Okay, so these are the topics I'm going to cover today. So really focus on the vaccine campaign plan, specifically for long-term care facility staff and residents during phase 1. So I'll give an overview of what the campaign plan is, some of the planning assumptions, and different options that long-term care facilities have available to them, and then the pharmacy partnership, and then lastly, talk about the sign-up procedure. Next slide. All right, so what we have on this slide is kind of a overview of the overall vaccine campaign plan. So really looking at a 3-phase plan, with phase 1 actually I've already started with, on the far left where we have no vaccine yet, but continuing to plan. And then phase 1 goes into the period of time where we have limited vaccine doses available, and those vaccine doses are highly prioritized. Once the vaccine supply gets to a certain number, then phase 2 will be declared, and that will be the phase in which anybody who wants to get a vaccine will have the ability to go and get it, mostly through their local pharmacy or their private doctor's office, or through different community events. And that phase will probably be the longest, pretty long phase actually. And then phase 3 will be when we transition to sort of a routine supply of vaccine, much the same way we do with the annual influenza shot. There's a potential that we might need an annual booster shot for the COVID vaccine. And so that would be all part of phase 3. The part that I really want to focus on is that red circle, talking about the time in which vaccine is very limited, and the phase in which we'll be addressing long-term care facilities. Next slide. So some of our planning facts and assumptions, many of the COVID vaccines are going to be 2-dose series, separated by 21 or 28 days. And that both doses will have to be with the same product. So if you get vaccine A for dose 1, then that vaccine A has to be administered for dose 2. In other words, no mixing and matching. And so this requires a plan for tracking who got which vaccine, and for sending out patient reminders so that they can come in and get their second dose. Cold chain requirements for the vaccine will have a range. So we're used to working with the flu vaccine that's stored at refrigeration temperatures from 2 to 8 degrees Celsius. But some of these vaccines will require ultra cold storage of minus 70 to minus 80. That is somewhat new from what we're used to. However, we do expect there will be some flexibility for short-term storage. For instance, the ultra cold vaccine can be thawed and stored at refrigeration temperature for a few days, provided that it's not mixed with the diluent. But still, the minus 80 product is pretty difficult product to work with, and generally we're not going to deliver that product directly to long-term care facilities, at least not early on in phase 1A and 1B, with the assumption that long-term care facilities don't have this frozen cold storage capacity on site. And there are different requirements for reconstitution, as I said, mixing with a diluent in order to make the vaccine ready to inject into people. Next slide. All right, so I want to talk a little bit about priority groups and how we designate priority groups. So right now we're working with some planning assumptions that the priority groups will be, primarily healthcare workers during phase 1A, and then certain other types of people such as residents of long-term care facilities during phase 1B. However, these recommendations are not set in stone yet. There is a group called the Advisory Committee on Immunization Practices, or ACIP. They're an independent federal advisory committee that provides recommendations on the use of vaccines. So basically, once a vaccine is approved for use, whether it's through an emergency use authorization from the FDA or a full licensure, that will trigger an ACIP review of the vaccine data to determine who is actually recommended to get the vaccine. So we know, for example, for flu mist, when it first came out, it was recommended for people up to the age of 50. And then later on, it was expanded to older age groups. And so the same thing could happen with the COVID vaccine, that they could decide that really people over a certain age shouldn't get the vaccine, whether that's 50 or 60, or they might decide that those people should get the vaccine and should be prioritized within the first tier. So those are all things that we don't know yet. So we're working on a lot of basically assumptions. The next, go back one. Yeah, so the next ACIP public meeting will be October 28th through 29th. We're not sure if they will actually have a vaccine candidate to review during that meeting, but this was scheduled some time ago. So this is a planned regular meeting that they're going to do. But again, as soon as we have a vaccine that's approved, ACIP will meet. They will provide recommendations as to who should get the vaccine, and then priority recommendations in terms of who should get it first and second and third and so forth. And then the CDC director can either accept the ACIP recommendations, or they can, substitute with their own recommendations. Next slide. So again, during this phase 1A, phase 1, we have it divided up into phase 1A and phase 1B. Phase 1A is really the healthcare worker or healthcare provider population. And so long-term care facility staff, even for assisted living facilities and independent living, could be included. And that healthcare provider is not limited to doctors and nurses, but anybody who is part of that delivery of care to that population. So food service, janitorial and custodial staff could all be included because they're, at risk for getting the virus and at risk for spreading the virus to this population. So they would be included in phase 1A. Phase 1B would include other essential workers, people at higher risk for severe COVID-19, people 65 years and older. And that people at higher risk includes people in congregate settings. So if we think of our long-term care facilities, our jails and prisons, our group homes, anybody in a congregate setting could be included in that phase 1B. Next slide. So when looking at the federal planning and their pharmacy partnership that they are setting up or have set up to meet the needs of long-term care facilities, I have a couple of options that will occur. The first one in the white boxes talks about, in that scenario where I said the ACIP does not recommend the vaccine for people with certain risk categories, that it's only recommended for, say, healthy people. In that case, we would only recommend vaccinating the staff of these facilities, and they would be included in the state allocation of vaccine intended for healthcare providers in the community. The second option is assuming the ACIP does recommend vaccination, both staff and residents. They would be included through one of two options, which I'll discuss today. Next slide. So this first option looks at the staff only, and this is assuming that residents aren't recommended for vaccine, or it could also include that time period during phase 1A when only staff are in that first priority group for vaccines. So the way this will work is that the staff of long-term care facilities would be included with other healthcare providers. They would be vaccinated, what we call the state allocation. So federal allocations are then divided into state allocations of vaccine. And then the state would determine where those vaccines will go within the state. So you'll see some of the options. The DOH stands for Department of Health. Occupational health clinics are another place that could get vaccine and vaccinate healthcare workers and our first responder community. Additionally, the Department of Health can set up, small mass vaccination clinic events. These would probably be closed just to the priority 1A group members, or we could send out mobile clinics using various mobile vaccination techniques. Next slide. Okay, but in the event that ACIP recommends that both staff and residents receive the vaccine, and as we move into phase 1B, there are really two options, and the facilities themselves get to choose which option they use. So one is that the CDC provides on-site vaccination services through their contracted pharmacy partners. And those pharmacy partners will receive direct federal allocations of vaccine. And the second choice is that the facility administers their own vaccine, either themselves or through a provider of their choice. So next slide. So the first option, the pharmacy contract option, the pharmacy contractors would provide on-site clinics for the facility, at the facility, for both residents and for any staff that have not already been vaccinated as part of phase 1A. These services would be free to the facilities. It's an end-to-end management by the pharmacy partner, so they will schedule and coordinate with the facility. And they will do all the vaccine ordering, distribution, and cold chain management. They will come on site and do vaccine administration to individuals, and then they'll do all the data reporting to the states and CDC. Next slide. And so this is kind of a sample of how this might look. So there might actually be multiple on-site events. So for example, on day 0, I might come in and give 1 dose to everyone in the facility. And then 3 to 4 weeks later, come and give dose 2 for everyone who received dose 1 already. And then maybe dose 1 for any new staff or new admissions that did not get the first dose. And then they come back a third time to give the second dose for everyone else. And then afterwards, the facility would transition back to their normal partnerships and arrangements for getting vaccine for any future residents. Next slide. All right, the next option I'm going to talk about is option B. Next slide. So in this case, a long-term care facility decides that they are going to do their own vaccinations, that they're going to register as providers and receive vaccine, or they're going to work with a local pharmacy of their own choice that's outside the federal contract. And in this case, the facility is responsible for all steps, including working with the state to sign the provider agreements, maintenance of cold chain of vaccines, and administration of the vaccine. And again, this could be either the facility signing up as a provider themselves or their partner pharmacy signing up as a vaccinator and doing these steps for them. And then the required data elements table, this is just showing when the vaccine doses are administered and then reported back to CDC and to the state's immunization information system. These are all the different data elements that have to be captured in that transmission. Next slide. So, who are the pharmacy partners? CDC is actually working with a lot of national, I can't speak today. Lots of national pharmacy chains to try and get vaccine out to as many places as possible. However, only CVS and Walgreens will be involved in the phase 1B effort to vaccinate long-term care facility residents. So these other pharmacy chains will probably eventually get vaccine through a federal level partnership. But for the long-term care facilities, the two ones that we care about are CVS and Walgreens. States can sign up additional pharmacy partners to assist long-term care facilities. And then the other pharmacies, as I mentioned, will receive and administer vaccine during phase 2. Next slide. So what do facilities need to do now? So starting 2 days ago, there was an opportunity that opened up for about 2 weeks for long-term care facilities to sign up for on-site clinics. And for assisted living facilities, they'll go through that red cap link that's shown there. And as they sign up, they'll provide their information and they'll choose whether or not they want to use the pharmacy option. And there's actually 2 choices. They'll get to choose CVS or Walgreens. And then other options they'll be able to select are to use an existing local partner or to opt out of these services altogether. So that's the end of my slides, pending any of your questions.
Thank you for the information. Any questions regarding the vaccination programs? Remember, you can raise your hand if you'd like to ask a question audibly, and we can unmute your line. You can also use *6, and you can use the chat function. There is a question in the chat. Have any of our long-term care pharmacies been approved? So I know there is Omnicare that a lot of the long-term care communities use, and that is a part of CVS. Is there a partnership there between the 2 channels?
Yeah, I'm not sure. I'd have to defer to Stephanie Wewell, who's our pharmacy expert on our team. I know that lots of facilities are signing up, including, local pharmacies and also long-term care pharmacies that are, part of are affiliated with the facilities can also sign up to become providers. And there's certainly an option to sign up as a provider with the state and still use the federal pharmacy partner option. So as I mentioned, during that phase 1B timeframe, the vaccine will be highly limited. The CVSs and the Walgreens will have some vaccine available to them through the federal allocation, and they'll come out and do the whole vaccination event from start to finish. But there may be some time period later in the vaccine campaign where the assisted living facility pharmacy on campus wants to provide additional vaccines to any new residents and staff that arrive at the facility after the federal partnership program has ended. In which case, if they want to do that, they will need to sign up as COVID-19 vaccine providers through the state by filling out the provider intent form.
Another question coming from chat. Will a staff or resident need to have a COVID-19 test administered prior to taking the vaccine?
That is a good question, and to say honestly, we haven't gotten any guidance on that. It's my working assumption that no, we won't test people for COVID before we vaccinate them. But that's really going to come out of any licensure guidelines that comes from the FDA and any recommendations from ACIP. So I really don't know the answer to that yet.
Another comment from a provider that talked to their long-term care pharmacy, and they have filled out papers to be a partner to give the vaccine, and there is concern about how long it will be before they get the approval. Any other questions or comments?
And I know the approval processes, I know we're getting a lot of those at the state level. Christy Gray, our vaccine unit director, would be the better person to answer that question in terms of how long it takes for approval. But I know we're anxious to get them approved pretty quickly and before we start to receive vaccine.
I don't see any other questions, but I just want to give a reminder that the sign up for facilities that are interested in having the on-site clinics from CVS or Walgreens, that window for sign up right now is open for 2 weeks. So please do use the links on the red cap if you are interested in having your community participate in that program. Thank you, Mike, for joining us today. We appreciate it.
You're welcome. Thank you.
Next on our agenda, we have the Virginia Department of Labor Workplace Safety Standards. And with us, we have Jennifer Rose joining us.
Hi, good afternoon.
Good afternoon, welcome.
It looks like somebody has put up all of the important web links here, and I'll also have a link directly to those at the end of my presentation, just talking about the specifics of where you can find certain information. So today, I'm going to talk about the infectious disease prevention, or the COVID emergency temporary standard that the Department of Labor and Industry has adopted. It is the in-state code. If you wanted to look that up, it's 16 VAC 25-220. I am the Cooperative Programs Director with the Department of Labor and Industry. My email address is right there. If you have any questions at the end of the presentation, or any questions that come up later, feel free to contact me, and email is the best way to contact me. So next slide. Talking a little bit about the emergency temporary standard. Basically, back in the spring, the Department of Labor and Industry identified a need for employee protections in the workplace from the SARS virus. So the intent of the temporary standard is to prevent the spread of the SARS virus in the workplace. It became effective July 27th, 2020, and this was after a very rushed process to get through the approval process. Basically, it involved several public comment periods, different drafts and reviews done by our Safety and Health Codes Board, and then finally adoption by the Safety and Health Codes Board after the final revisions have been made. The standard takes a tiered approach to looking at employees' exposure in the workplace. Basically, one of the requirements of the standard is that employers perform a hazard assessment. Basically, they're looking at what kinds of hazards are in the workplace, or how employees are going to be exposed potentially to the virus in the workplace. And from that, then they look at classifying which exposure risk level they are in. There's the very high, medium, and lower exposure risk levels, which are all defined in the standard, but basically they are based on the employee's exposure in the workplace. You know, the lower is if you've got employees teleworking, or there's no opportunity for them to have contact within 6 feet of any other employees or the public or patients or things like that. Medium is where they have potential exposure to those within 6 feet of the suspected or not suspected to be COVID-19 positive patients. And again, these are things like retail industries, restaurants, certain workplaces that have employees standing side by side. And then we get into the high and very high risk categories, where typically the long-term care and assisted living facilities will rank, just because they are, do have that higher potential for exposure to positive employees. So once the assessment has been made and the employer has determined what level, exposure risk level they have, the standard gives different requirements for each of those specific levels. If you break down the standard into 4 different sections, and it is a pretty lengthy standard, but this is kind of my way of piecing it down to make it a little more understandable. First part involves the workplace assessment. And as I said before, this is required of employers to perform a PPE hazard assessment to look at any job tasks, any products that they use, or processes that employees may be exposed to that virus. And then you want to look at control measures. So after you've determined what exposure risk level your employees are at, you want to look at how you're going to control their exposure in the workplace. Are these things like respirators, N95 respirators, or surgical masks, or do you have physical distancing procedures in place, things like hand washing, and all the different controls with engineering, administrative, and personal protective controls that your employer has decided to be effective in the workplace. After all that has been done, the employees need to be trained on the policy, that the written plan that is required by the standard. Employees need to be made aware not only that the standard exists, but basically what is involved in the standard, and then specifically on what types of controls or policies and procedures are in place at your work site. And all this has to be documented in a written plan, which there are certain elements that have to be included in the written plan. This is one of the documents that is available on our webpage that I'll give you at the end. There's a template for a written plan, and basically any employer can use it, and they just fill in the blanks, going through the different sections and putting in there what basically specifics of their procedures and their exposures at their work site. I do want to mention one thing about CDC and VDH guidelines. This emergency temporary standard, it was adopted back in July. And since then, the CDC has come out with some adjustments to their guidelines. One of the parts of the standard does allow for employers to follow CDC guidelines that may be different than what's required in the emergency temporary standard. The provision basically allows employers to do this so long as they can provide documentation on what specific guidelines they're following. And with this, you want to also look at things like VDH guidelines and other licensing requirements that may be required for your industry. And you'd want to obviously look at whichever is the more stringent requirement, just so that you're ensuring that your employees are protected to the fullest possible as they can. This is an emergency temporary standard, which means that it was put into effect for 6 months. So in January, the temporary standard expires, but we are currently in the process of developing a permanent standard. Again, this would have to go through the same rulemaking process with the public comments and the Safety and Health Codes Board's input to that. But once that is potentially adopted, all of the requirements here, plus a couple of revisions that we've taken so far from the public, would be included in the standard. Next slide. a little bit about our agency and basically how we would go about enforcing this emergency temporary standard. Again, even though it is an emergency standard, it is full force. We enforce it just like we would any other safety or health standard required by VOSH. Our enforcement process basically includes reporting of the hazards, such as if we get a report from an employer of a fatality, or you have 3 cases or more of COVID in the workplace, or complaint items. This is probably the biggest category of where we're hearing about what's going on in the workplace is employee complaints. But these complaints or reports of fatalities come into our regional offices, and basically the way that they're handled is right now as a starting point, our regional directors or enforcement officers will contact the employer, discuss with them, what the issue is. Obviously, if they've had a fatality, we will be investigating that, as well as the 3 or more cases within a 14-day rolling period in your workplace. From there, our staff will do investigation, asking things like, when was the last time the positive employee was in the workplace? How long have they been, who they were exposed to, what kind of tasks they were doing, things like that, to get us more information about, determining whether or not it's more likely than not that the exposure happened in the workplace. And that's kind of that judgment thing that we're looking at as to how we go about enforcing the standard, is whether or not that exposure was more likely than not to happen in the workplace. From there, the enforcement process typically would potentially involve an on-site visit. Right now, we are trying to limit the number of on-site visits that we do unless they are absolutely necessary. We're trying to deal with things over a phone or email process right now, but we do have enforcement officers going out into the field, particularly for complaint issues, or if we've got concerns at the workplace that haven't been addressed. So the conduct of inspection, again, if we have situations where our enforcement officers would be going out to a site, they would come out, with no notice, do a review of your written programs, look through any written policies or procedures that you have, any 300 logs for records of any exposures, things like that. And then they would do a walkthrough, looking for those control measures that you have currently in place. One of the big things with the standard, because this is an unprecedented issue and a relatively new issue that can be enforced, Virginia was the first state to actually implement a standard on COVID, and so other states are using ours as a reference. But basically, those measures that are covered in the standard, that are required to be covered by employees in their plan at their facility, the enforcement officer will look at those, see kind of what's included in that, and if there's any deficiencies. One of the things with the standard, again, because it is kind of new to everybody, good faith effort goes a long way. If you get to the point where you have been, there's an open investigation at your site. I understand that there, especially in the long-term care and assisted living industry, y'all do have other agencies and organizations that are requiring certain things of your workplaces. So, taking into account those controls that you've implemented, as well as how that relates and sometimes overlaps what our regulation requires. A little statement about citations and penalties. Just like any other standard, if an enforcement officer were to find deficiencies in the workplace and where the employer is not following the requirements in the standards, they can potentially be issued with a citation that includes penalty amounts. Already you're seeing fear mongering in the industry. I've seen a couple of articles written by supposed safety experts warning employees of, $12,000 and up fines from not having, hand washing stations or hand sanitizer, whatever the issue that person has brought up. I do want to just make you all aware that those are extreme cases. Basically, our citations, the penalty amounts related to citations, there are many factors that go into that. And there's also additional reductions in those penalties based on things, like I said, good faith, the size of your establishment, as well as any previous history with enforcement. Next slide. So some statistics specific to long-term care and assisted living facilities. And this is data going back from January 1st to October 10th. We've had over 8,000 calls from the public and employees specific to issues at assisted living sites. This had included 1,138 complaints from employees that have been filed with us. These complaints, as well as fatalities and hospitalizations, have resulted in only 69 inspections in your industry, which in the whole realm of enforcement inspections that our 58 officers do on an annual basis is kind of low compared for the industry. We have had reports of 56 hospitalizations. In 20 of those cases, they have resulted in an on-site inspection by our enforcement officer, but the majority of them, at 36 of those, are covered or addressed basically just over the phone and through written communications with the employer, and did not result in an on-site inspection. We have had reports of 24 fatalities at long-term care and assisted living facilities. Obviously, fatality investigations are conducted as a result of us learning of fatality. You are, just like any other fatality at your workplace, required to report that to us within 8 hours of the fatality. There are also requirements for reporting hospitalizations, as well as 3 or more cases of positive COVID employees in your workplace. But the fatality all do get an on-site inspection conducted by our enforcement officers. And we've had 131 cases reported to us where there have been 3 or more employees that have had a positive test in their employer. So 131 different employers have reported those positive case results to us. Next slide. Actually, you know what? All these, I'm sorry, could you go back? All these statistics are all industries. I knew something was off there. This is the total industries for both construction as well as general industry that we've had. So again, that's why that 69 inspections is very low compared to our typical inspections at other workplaces. Our next slide shows the statistics specific to assisted living facilities. And again, this is an even lower percentage of what we're doing and places that we're inspecting. We've only had 3 inspections in this time period at assisted living facilities, and one of them was as a result of a fatality at one of the sites. Primarily, we're seeing complaints coming in from employers, and the most typical complaint that we hear from employees is that the employer is not providing proper control measures. And oftentimes what we see once we begin the investigation of the work site is that the employees are just don't have an understanding of what control measures are actually already in place at the workplace. So I do want to mention that it is very important to train your employees on what control measures you have in place and why you have them in place, so that they are aware of what efforts you have put in to protect them. Phone and fax investigations, again, this is the majority of what we're doing as far as investigations without those on-site inspections. We're handling things over phone and fax just to avoid our employees' exposure and our officers going into those high-risk employer sites. Citations specific to assisted living, because we have 6 months to issue citations. So far, we have not had any citations issued yet on those 3 inspections. So I can't really tell you what kind of things they're finding. but like I said, I suspect things that may be related to control measures, because typically that's where our complaint items are coming from. Frequently asked questions. We're hearing a lot of employees and employers contacting us about control measures. You know, what's sufficient? What kind of PPE do I need to be providing employees, and what if it's not available? And things like hand washing and all these other different engineering, administrative, or PPE controls that can be in place. So as best practices that we've seen so far in the assisted living facilities that we have talked with, and this is also, my opinion, just based on safety industry as a whole, is the importance of communication between the employer and the employee. The employee needs to know what the employer is doing to protect them, and the employees need to feel safe coming into their workplace, knowing what controls the employer has put in place. And through employee feedback, this is another way that employers can increase that communication, is asking for that employee feedback. What concerns do you have about your exposure in the workplace, or the availability of PPE, or anything that they might have concerns over, that they should feel comfortable bringing those to you. One of the things that I'll note from the standard is that there is an anti-discrimination portion of the standard, which, just like we do with any other standard, employees should not feel discriminated, or should not be discriminated against for reporting unsafe work practices in their workplace. Again, there are protections in place for those employees who feel that they've been discriminated against, lost their job, been given, different layoffs, things like that. So again, those best practices, just making sure that you're communicating with your employees and seeking their feedback. Next slide. So one of the things that our state agency, we're not just enforcement. When lots of people think of OSHA, they think of the people in the white hats coming out, doing inspections and issuing citations and penalties. But what a lot of employers are not aware of is that we also offer a free consultation service to small employers with less than 250 employees at their site, or less than 500 corporate-wide. And with this service, at the request of the employer, you can request one of our consultants to come out to your workplace and do an assessment, similar to what an enforcement officer would do, in looking at all of your written programs, walking through the site, looking for any citable hazards. Right now, we are doing, our consultants are doing virtual visits primarily, where we're getting a lot of questions answered over the phone, reading programs, and helping employers with things like virtual training. We do have very, very stringent requirements of our consultants on where they can and cannot do an on-site visit right now. So it really just depends upon the industry. But like I said, we are still offering services, even though we are limiting our on-site inspections. Right now, our consultants can help you specifically with your written COVID plans, with doing the assessment of your workplace, all of those different requirements in the standards. Our consultants are there to help you and guide you through that process. Again, my email address is the best way to reach me. I would first start, if you had questions, I would reference you to our agency webpage. We do have a dedicated page for coronavirus resources. On that page, you can find the full text of the standard, as well as any of the required documents, so things like the hazard assessment. There's a blank form on there and instructions on how to fill that out. There are training PowerPoint presentations that meet the requirements for those medium, high, and very high exposure risk level employers that have to provide that training to their employees. There's also a written plan, like I mentioned, where the employer just fills in the blanks basically, and the result is that you have a plan that is in compliance with the standards. We do have a dedicated web page specific to COVID-19. We have several staff responding to these emails. So if you have specific questions or concerns, you can direct them directly to that web email address. And as a requirement, again, in the standard, if you have 3 or more cases at your facility within a 14-day rolling period, you are required to report that, as well as any hospitalizations or fatalities, to the Department of Labor and Industry. And front and center on our webpage, we do have a link for employers to access a online reporting portal where you give all the information that we need to be able to respond to that report. We are working cooperatively with the Department of Health, and they are receiving these reports as well. So we're working cooperatively because the standard does talk about notifying not only us, but the Department of Health, and this portal, this online process allows you to do both at the same time. So that's all that I have. I guess if we can take any questions now.
Thank you, Jennifer, for the updates. Are there any questions regarding the new temporary standards? If there are no questions at this time, as always, if you have questions, you can feel free to reach out using the website links that are provided and the email addresses. Also, if you have questions, you can send them to me. Again, I'm Judy Hackler with VALA, and we can forward them on to the appropriate agencies. Thank you, Jennifer, for being with us. We appreciate it. The last part of our discussion today, we just wanted to provide an update on the last couple minutes of our call on the Virginia General Assembly. So I want to invite Julia Hammond, who is the lobbyist for VALA, to join us on this conversation. Julia may be on mute, might be having some technical difficulties, but we do have some updates on legislation that was passed during the special session. And on the screen, you will have updates. We have direct links to the bills if you want to see the specific language. One of the bills that was previously signed is with regards to civil liability immunity, and it does include assisted living communities, and that went into effect on October 13th. Of course, that does not include liability for purposeful acts of negligence. But in general, the assisted living communities will have the civil liability immunity. There are also some updates on the website as far as the other bills on outbreak reporting that you see on the website. They were just recently signed by the governor, and so they will go on to be approved and have the regulations written by their respective agencies. Other bills that were signed by the governor are telemedicine services, as well as visitation requirements for nursing homes and hospice facilities. There is a task force that is working on those regulations, and that will be presented and then go through the regulatory process. Any other questions or comments that you'd like to share? Last thoughts? You may use the chat, or you may unmute your line or raise your hand if you have any questions or comments. Not seeing any. I thank you all for joining us today. We will send out a link for a survey. If you could please complete that. That way we can update future presentations and be able to provide you information that would be relevant for you and your community. For those of you that have registered and provided an NAB registration number, we will also upload your CEU information to NAB on your behalf. We thank you all for joining us, and we look forward to seeing you at one of our future webinars. Thank you so much.